So we wanted to talk a little bit about the physiology of the brain death itself, and kind of what this does is this takes the physiology that we talked about the lungs and now brings it towards engaging it with the brain death process. And then after we do this, we'll then talk about how we manage neurologically deceased donors and how we do aggressive lung donor management. Okay. So once again, any questions, stop me along the way. Brain death is associated with a widespread, lots of physiologic changes that occur across multiple systems in the body, and it can cause primarily hemodynamic compromise, and that's the biggest thing we worry about. This graphic is quite overwhelming, but it sort of talks about everything that happens in the brain death process. So you start out with severe brain injury, and you don't have to copy this stuff down because these slides will be available to you as soon as I get them in a format that I can share with you. I just went from IBM to Mac, and I don't know Mac well enough, and I need to get, you're a Mac person? Much better. I can't get all of my old lectures. I switched them over, but then I couldn't get them to project up here. So I'm using older talks, but I'll get the more up-to-date talks for you when I can get them. Anyway, so you go from severe brain injury to cerebral ischemia. And from there, you go on to brain death in the worst case scenario. Obviously, we'd rather people not go on to brain death, except for we need to have organs, and sometimes it's okay if it's, I guess. The brain death process causes a number of different responses in the body. It causes a sympathetic response. It causes a parasympathetic response. It causes pituitary hypothalamic dysfunction. It causes pro-inflammatory cytokine release, and it causes coagulopathy. And each one of those things then goes on to cause physiologic changes. So when you have a sympathetic response, you end up getting hypertensive and vasoconstrictive. When you have the parasympathetic response, you get hypotensive. When you get the pituitary hypothalamic dysfunction, you get loss of thermal regulation. You can either get hypothermic or hyperthermic. You can also get hormonal imbalance where you have electrolyte disorders and water problems. The pro-inflammatory cytokine release causes direct injury to the vital organs, and those are the ones we'd like to transplant. And then you can also get a coagulopathy, which also causes damage to the organs, and it can infiltrate the organs with lots of little microthrombi that can cause significant dysfunction and render those organs not transplantable. From there, the primary issue we worry about is hemodynamic instability, which ultimately also causes damage to vital organs, and that's what we want to try to prevent. So during the process of herniation, the body is designed to try to preserve cerebral blood flow above all else. And it does this by stimulating the vagal and the sympathetic systems. The ultimate decompensation is Cushing's triad, and Cushing's triad is when you start to have active herniation, you get hypertensive bradycardic, and you have an abnormal breathing pattern, and then you go on to have decompensation and arrest. Brain stem ischemia causes necrosis of the nerve cells in the medulla, which is the middle part of the brain stem. This causes unchallenged sympathetic activation. What that does is create what we call the autonomic storm. And the autonomic storm is where you release about 800 to 1200 times of the normal levels of catecholamine in the bloodstream. You release this all at once, and that's the so-called catecholamine storm. The primary catecholamine in your body that you release is what? Do you guys know? Norepinephrine. Okay. And then a little bit of dopamine and some epinephrine, but it's primarily norepinephrine. And so what you have is you have increased systemic vascular resistance. You have cardiac output issues, heart rate problems, MAP problems, and you increase your myocardial oxygen demand. This can then lead to myocardial ischemia and or arrhythmias. You know that catecholamines cause increased myocardial consumption of oxygen. And at the same time, it causes decreased coronary blood flow, and so it can be problematic. You can get arrests during that time. Okay, spinal ischemia can occur minutes to hours after this initial storm, and at this point, you lose your sympathetic overdrive, and you now have significant vasodilatation. You decrease your blood pressure, your heart rate, and you decrease your contractility. And this represents the greatest risk to potential donation of organs, because then your organs suffer a second hit ischemic insult, and so you get a big issue. So this is just a cartoon graphic to think about what happens during the brain death process. So you start out with about 7 liters of circulating blood volume. you have this big catecholamine squeeze, and you squeeze down to about 5 liters because you've vasoconstricted so much and you've put fluid out of your intravascular space. Then you lose all of that tone. Now you have a sink that can hold 10 liters, but you only have 5 liters in it. And that's the graphic that I think is the most important, which is why I say that one of the things we need to do pretty quickly after we get on site is give volume. Do you guys use minimally invasive hemodynamic monitors? Use the flow track, or what do you use?
Stars. Yeah. Starling. PG.
Yeah. Yeah. Okay. All right. Yeah, I mean, they all give you about the same idea, but I mean, mostly you're looking at pulse pressure variability, stroke volume variability, and giving volume based on your stroke volume and pulse pressure variabilities. Is that what you use them for?
We see whether or not they are fluid responsive
Based on,
doing fluid challenges or passive leg raises. And then if not, if we're having issues cardiac wise, it gives us like those non-invasive cardiac numbers.
yeah, what numbers do you use? Do you use the stroke volume variability or blood or pulse pressure variability?
Just give you like stroke volume and stroke volume and.
Yeah. Okay. All right. Sounds good. That just gives me a reference. So thank you.
Yeah.
All right. So the progression of ischemia starts from the head downwards, or what we call the rostrocaudal direction. So you start out with the cerebrum herniating. That causes a drop in heart rate, drop in cardiac output, blood pressure. Then you get pituitary gland and hypothalamic gland destruction. Then you start going down and putting pressure on the pons, which actually causes a sympathetic response, and you get increased heart rate, or decreased heart rate, but increased blood pressure. This is where you get the Cushing's triad. Then you go down to the medulla, you increase heart rate, increased blood pressure, temp instability with more sympathetic or autonomic storming occurring at this point. And then you go to the spinal cord where you all of a sudden lose all your sympathetic tone and you have the big vasodilatory component. In terms of hormones, you have a decrease in antidiuretic hormone or vasopressin, T3, cortisol, and insulin. And this can cause significant electrolyte disorders. The classic is you go into DI. And remember, in DI, you lose what primarily? Fluid, right? So I always think about DI and SIADH as not a salt problem, even though your sodium changes, it's really a fluid problem. And so when you have loss of the ADH, you just start dumping volume and your sodium will climb because of that. T3 is interesting. Theoretically, you switch in your cardiac cells from an aerobic to anaerobic metabolism when you have a lack of thyroid hormone. You get increased lactate and acidosis and myocardial dysfunction. And then from a hypothermia standpoint, when you lose function of the hypothalamus, you get hypothermic, and this contributes to hemodynamic instability as well, in addition to myocardial depression and arrhythmias, reduced oxygen, tissue oxygenation, and impaired kidney function. And lastly, with neurologic damage to the brain, you get coagulopathic because you start to release tissue thromboplastin and plasminogen from necrotic brain injury. This is more of an issue with traumatic brain injury than it is with complete herniation, but it can happen with herniation. With traumatic brain injury, you may notice that your coags are often quite bit out, and that's because the tissue plasminogen and the thromboplastin get released from that dead brain tissue. And so this can contribute to worsening bleeding. And then in terms of pulmonary blood flow, what happens is that when you have the autonomic storm phase, you get a significant increase in your left atrial pressure. So you get vasoconstriction, which causes left ventricular outflow problems, and everything gets backed up. So you back up pressure into the pulmonary veins. And what happens is you have a right ventricle that's functioning properly and a left ventricle that's backed up. And so if you have pump forcing this way and it's forcing this way, the fluid leaks out into the lungs. And that's why you get the so-called neurogenic pulmonary edema. That's at least the simplistic pediatrician's way of thinking about it, because you just get back up because you got so much vasoconstriction. Remember that drugs like norepinephrine, they don't really affect the pulmonary vascular bed as much as they affect the systemic vascular bed. So you don't get pulmonary vasoconstriction, you just get systemic vasoconstriction. Okay, this leads to neurogenic pulmonary edema. It can also lead to pulmonary hemorrhage. And so it also will tell you that your CBP may not be an accurate measurement of left ventricular function, which is why I was asking about your minimally invasive hemodynamic monitors that you use. Because those are going to be much, much more reliable on telling you whether you're going to be volume responsive or volume unresponsive. The electrolyte imbalances that you can have can be hypernatremia or hyper or hypokalemia, hypocalcemia, and hypo or hyperglycemia. Those are all very common to see. So with the brain death process, you'll develop diabetes insipidus, which can lead to dehydration. It can also lead to the electrolyte disorders we talked about. That gives you less preload. With the brain death process, you also have loss of vasomotor tone, which leads to less preload and less afterload. And the hormonal depletion will lead to less preload and less afterload, in addition to some anaerobic metabolism. If you have less preload and you have less calcium channel stimulation, remember that your body is dependent on calcium for contractility, particularly the myocardium. So if you're hypocalcemic, then your myocardium doesn't contract as strongly because calcium is what ties the actin and myosin muscle fibers together and causes the pulling. I don't know if you know about that, but there are two calcium molecules that do that. So when your ionized calcium gets low, it's actually a negative inotrope. So you want to get their calcium up to a normal level. Calcium is probably one of the better inotropes we can use. That's a physiologic inotrope. And so I follow ionized calciums. Do you guys follow your ionized calciums closely?
Yeah.
That's why you do it, right? Because you follow ionized calciums as a reflection of making sure that you keep that in the high normal range to take advantage of the contractility benefits of it. But in addition, when you get less afterload, then you get less coronary perfusion, because remember that your diastolic blood pressure is what creates pulmonary coronary perfusion. And so if you have a lower diastolic blood pressure, because you got less systemic vascular resistance, you have less coronary blood flow. And so it sets you up to develop myocardial ischemia. And all of these things cause cardiovascular dysfunction and decrease oxygen delivery to the organs. So the goals of donor management then are to support the donor through the physiological derangements of the brain herniation process to try to minimize the oxygen, lack of oxygen damage to the potentially transplantable organs. Or in other words, you want to just provide excellent ICU care in one of the situations that's probably the most physiologically challenging, so you can actually save up to 8 lives. So, and this is what I tell ICU people. And you know, when I talk to them and do grand rounds for ICU folks, these are some of the more important points, because you know that the individual that you're caring for you're not going to be able to do anything for, but by using your skill set as an excellent intensivist and really paying attention to what's going on, you can potentially help other people. Okay, that's all we're going to talk about in terms of the brain death process. Any questions about that or the effects of brain death on your physiology?